Hello everyone, good afternoon and welcome to the session. Today we will discuss about the approach to inborn errors of metabolism. So, what are IEMs? Inborn errors of metabolism are biochemical genetic disorders in which there will be a gene mutation which leads to absence or deficient activity of a single enzyme in a metabolic pathway. Or it might be also a co-trans factor or transporter deficiency which leads to accumulation of the precursor of the enzyme or the byproduct. That is, the substrate will be in excess if the enzyme or cofactor is deficient. So generally there will be some misconceptions about the IEMs, like the IEMs will be difficult to diagnose, and if most of the IEMs present similar to sepsis, the features will be similar to sepsis. In that situation, it will be difficult to diagnose, and they are very rare conditions, and like it will be difficult to diagnose as well as treat them, and the IEMs occur only if there is a family history. So most of these are wrong misconceptions. We'll see why. So even though the incidence of each individual inborn errors of metabolism is rare, but collectively the incidence will be common. Like the incidence is around 1 in 1,000. Until date, there are more than 500 inborn errors of metabolism which are recognized. And the age of presentation of IEMs is varied. Some of the IEMs like non-ketotic hyperglycemia present in utero period as well, and some of them present in the later stages like mucopolysaccharidosis and all. They present in later periods of infancy, and some of them present even in adulthood as well. So most of the IEMs are inherited as autosomal recessive conditions in which both the parents will be in the carrier status and they may not have any symptoms. So in that case, the family history, obtaining the family history assumes more importance, because history about previous sibling deaths or affected siblings or affected family members is very important to diagnose the inborn errors of metabolism in the index child. Some of the IEMs are X-linked inheritance, and as well as autosomal dominant and X-linked dominant inheritance is also possible. Mitochondrial inheritance is also possible, in which the inheritance occurs only from the mother to all her siblings, but the father will not transmit the disease. So let's see some of the introductory aspects about the IEM. So as I said already, the history is very important before approaching a case of suspected IEM, like there was any history of consanguinity or history of high drops in the current baby or the previous baby, history of IUGR or previous affected siblings, affected family members. And most of the IEMs have non-specific signs like lethargy, poor feeding, seizures, respiratory distress, and hepatomegaly, jaundice, so which occur in many of the other conditions like sepsis, other causes of jaundice, as well as cardiopulmonary dysfunction. So a high index of suspicion is always necessary. And whenever a baby presents with features of sepsis-like features with culture negative, then we should always think about the next possibility, which is inborn errors of metabolism. And the misconception about diagnosis being very difficult is also wrong. If we follow the algorithmic approach, the diagnosis becomes simpler, and there are now many tests which are helping making the diagnosis of inborn errors of metabolism easier, like tandem mass spectroscopy, TMS, urine for GCMS, and molecular studies. All these help in diagnosing the IEMs. And there is one more misconception that breast milk should never be given to a baby with the suspected IEM, which is also wrong. Whenever you have a baby with suspected IEM, like having a previous sibling death and the diagnosis is yet to be confirmed, in that case, you can initiate the breastfeeding in a quantified amount, keeping in mind the complications to look for and the investigations to see, and considering the nutritive value of the breast milk. Coming to the classification of IMs. IMs are broadly divided into three groups. The first one is the small molecule involved, that is the intoxication disorders, in which there will be a deficiency of an enzyme or a cofactor that leads to the accumulation of the substrate or the byproduct. So this can be amino acid based disorders, urea cycle disorders, organic acidemias, and disorders related to the metabolism of sugars. So in this, the child will be normal at birth, but presents early, that is on day 2 or day 3 of life, with neurological deterioration, lethargy, seizures, hypotonia, poor suck, feeding difficulties. So examples are for this are maple syrup urine disease, methylmalonic acidemia, propionic acidemia, ornithine transcarbamylase deficiency, galactosemia, etc. The features of this group of IEMs resemble sepsis. Like in this, the baby will be having the respiratory distress, needing ventilatory support, organomegaly, shock, and lethargy, seizures. So, but it resembles sepsis, but the culture will be negative, and we should be able to treat the metabolic crisis that occurs in this group. So coming to the second group, which is the energy failure group, in which there will be a deficiency in energy production or utilization in various organs like liver, brain, and heart, which leads to the production of the symptoms. So these are seen in mitochondrial and cytoplasmic energy defects. So the symptoms in this group will be hypoglycemia, hepatomegaly, hypotonia, cardiomyopathy, and a previous history of sudden infant death syndrome. These babies also are normal at birth, and the symptoms occur later on. So examples for these are congenital lactic acidemias, pyruvate carboxylase deficiency, pyruvate dehydrogenase defects, disorders of gluconeogenesis, and fatty acid oxidation defects. So the hypoglycemia will be refractory in these conditions, requiring high GIR and difficult to treat. So mitochondrial disorders are mostly untreatable except for fatty acid oxidation defects, in which we will give carnitine treatment, and coenzyme Q defects. The third group is the storage disorder group, in which there will be a deficit in the synthesis, remodeling, and recycling of molecules in the cell organelles. Example, lysosomes, peroxisomes, endoplasmic reticulum, Golgi apparatus, and mitochondria. So these present slowly in the infantile period, have a slow indolent course that occurs due to the intracellular accumulation of these metabolites. Example, plasminogen and very long chain fatty acids. They have a delayed onset, hepatosplenomegaly, bone involvement, etc. These examples will be, because it involves the lysosomes, peroxisomes, lysosomal storage disorders, peroxisomal disorders, alpha-1 antitrypsin deficiency, congenital disorders of glycosylation. For these, the treatment will be enzyme replacement therapy for lysosomal storage disorders. So now let us see the common clinical presentations of the different IEMs. So some of the IEMs, like I said, NKH and fatty acid oxidation defects, they might have a fetal presentation in which there will be, mother will be able to feel the seizures in the third trimester, in the intrauterine period itself, and high drops. Antenatal ultrasound will be showing ventriculomegaly, cerebellar hypoplasia, brain atrophy, subcortical cyst, corpus callosal agenesis. This is seen in NKH. And once the baby is born, baby might be floppy, like having hypotonia and dysmorphic features. We'll be seeing the different dysmorphic features in different IEMs. And baby might be having different congenital malformations and will present in one of these three clinical presentations which we have discussed earlier. That is, intoxication group means child will present with altered consciousness, seizures, and hypotonia. If there is energy failure, baby will present with refractory hypoglycemia requiring high GIR. And in the visceral involvement, there will be liver failure, hepatomegaly, cholestasis will be present. And IEMs are characteristically associated with abnormal odors of urine or skin, as well as some skin and different eye presentations, which we will see one by one. So coming to the dysmorphic features which are generally noted in inborn errors of metabolism, I have mentioned some common syndromes. Suppose in Zellweger syndrome, the features will be large fontanelle, prominent forehead, and flat nasal bridge, epicanthal folds, hypoplastic supraorbital ridges. In pyruvate dehydrogenase deficiency, there will be epicanthal folds, flat nasal bridge, small nose with antiverted flared alanacei and long philtrum. In glutaric aciduria type 2, there may be macrocephaly in this case, high forehead, flat nasal bridge, short nose, ear anomalies, hypospadias, and rocker bottom feet. In cholesterol biosynthetic defects, that is Smith-Lemli-Opitz syndrome, the features will be similar: epicanthal folds, flat nasal bridge, syndactyly, genital abnormalities, and cataracts. In congenital disorders of glycosylation, inverted nipples, and lipodystrophy. In lysosomal disorders, there will be Hurler-like phenotype, that is coarse facial features and large tongue. In Miller syndrome, dihydroorotate dehydrogenase deficiency, there will be micrognathia, cleft lip and palate, malar hypoplasia, eyelid coloboma, downward palpebral fissures, and absence of the fifth region. So if you see in each syndrome, there is one characteristic feature is there. So, like in Smith-Lemli syndrome, there is syndactyly. In Miller syndrome, there is cleft lip or palate. And lysosomal diseases, Hurler's-like phenotype. Zellweger syndrome, Downs-like features. So macrocephaly in glutaric aciduria. If we see the baby and identify the features in the baby and we correlate it to the particular syndrome, we will be able to narrow down the diagnosis. So let us see the different systemic involvement which is associated with the inborn errors of metabolism. So IMs associated with liver involvement, they are associated with hepatic cell failure, that is galactosemia, tyrosinemia, and neonatal hemochromatosis. Associated with cholestasis, they are alpha-1 antitrypsin deficiency and mitochondrial hepatopathies. If hepatosplenomegaly along with hypoglycemia is there, then Gaucher's disease, Niemann-Pick's disease, and GM1 gangliosidosis should be kept in mind. So IEMs associated with cardiac involvement, cardiomyopathy, or fatty acid oxidation disorders, glycogen storage disorder type 2, that is Pompe's disease, and congenital disorders of glycosylation. Associated with hydrops, these are lysosomal disorders, Zellweger syndrome, GSD type 4, congenital disorders of glycosylation, and neonatal hemochromatosis. Skin manifestations are seen in biotinidase deficiency, Hartnupp's disease, and holocarboxylase deficiency, in which there can be alopecia and exfoliative dermatitis and acrodermatitis enteropathica-like features. Abnormal urine orders are seen in maple syrup urine disease, isovaleric acidemia, cystinuria, tyrosinemia, phenylketonuria, and glutaric acidemia type 2. So coming to the different urine orders in IEMs. In MSUD, the order will be like maple syrup only. Musty and mossy orders are seen in classic phenylketonuria. Cat urine type order seen in multiple carboxylase deficiency. Sweaty feet order in glutaric aciduria type 2, isovaleric acidemia, 3-hydroxymethyl glutaric aciduria, and cabbage-like order is seen in tyrosinemia type 1 and methionine malabsorption. Acid smell seen in methyl malonic acidemia. Sulfur-like order is seen in cystinuria. Old fish-like order seen in trimethylamminuria, dimethyl glycine dehydrogenase deficiency. So most of this is of theoretical aspect, which might be asked in the different multiple choice as well as OSCEs. So it's important to remember them as much as possible. So coming to the neurological manifestations of the IEM. So as we discussed, they may present as encephalopathy or predominantly seizures, and both encephalopathy and seizures, as well as hypotonia and apnea. So predominantly encephalopathy is seen in organic acidemias, maple syrup urine disease, fatty acid oxidation disorders, disorders of pyruvate metabolism, glycogen storage disorders, In FAOD and GST, they will be having hypoglycemia as well as encephalopathy, and mitochondrial disorders, hyperammonemias, and GLUT1 transporter defect, as well as hyperinsulinic hypoglycemias. Predominantly, seizures are seen in pyridoxine responsive seizures, in which there will be refractory seizures, which are refractory to multiple anti-epileptic drugs, as well as pyridoxal phosphate responsive epilepsy, biotinidase deficiency. So in biotinidase deficiency, along with seizures, there will be skin manifestations also, as we already discussed, and cerebral folate deficiency, sulfite oxidase deficiency, molybdenum cofactor deficiency, and NKH. NKH can present right from the time of birth and from intrauterine also. This is due to the elevated glycine levels which affect in the brain. And hypotonia is mostly seen in mitochondrial disorders, Zellweger syndrome, glycine encephalopathy, sulfite oxidase, and molybdenum cofactor deficiency. Recurrent apneas may also be a feature of IMs, which is seen in glycine encephalopathy, MSUD, urea cycle disorders, disorders of pyruvate metabolism, fatty acid oxidation disorders, and mitochondrial disorders. So coming to the ocular findings in inborn errors of metabolism, these are also important. Like macular cherry red spot is seen in GM1 gangliosidosis, galactosialidosis, Niemann-Pick disease, and Tay-Sachs disease. Retinitis pigmentosa in mitochondrial disorders, peroxisomal disorders, and A beta lipoproteinemias. Optic atrophy or hypoplasia seen in pyruvate dehydrogenase complex deficiency, Leak's disease, and peroxisomal disorders. Cataract is seen in galactosemia, tyrosinemia, peroxisomal disorders, and Lowe syndrome. Dislocated lens in sulfite oxidase as well as molybdenum cofactor deficiency, corneal clouding and opacity seen in mucolipidosis and mucopolysaccharidosis. So many IEMs present with different manifestations of ocular findings. So the IEMs are broadly classified into metabolism of different components, that is proteins, carbohydrates, as well as lipids. Among the proteins, we can divide them into amino acidopathies, organic acidemias, and urea cycle disorders. Among the metabolism of carbohydrates, we can divide broadly into disorders of gluconeogenesis as well as glycogenolysis. Metabolism of lipids is fatty acid oxidation defects and cholesterol biosynthetic defects. So whenever we find a baby who is having some of the above mentioned symptoms, like either neurological symptoms or hypoglycemia or metabolic acidosis or liver involvement, which is not responding to the usual treatment, so then we should approach the baby starting from the antenatal history to make a proper diagnosis. So in the antenatal history of consanguinity is important, history of frequent miscarriages, previous obstetric history, previous sibling deaths is important, and as well as 3-generation pedigree chart, which shows the affected other family members, and previous history of sibling death, sudden infant death syndrome, global developmental delay, mental retardation in the previous child. So all these sort of important in IEM, but negative family history does not make like sometimes a mother will be a primary mother, firstborn, both the parents might be autosomal recessive. In that condition, there will not be any significant family history, but it does not rule out the possibility of IEM. And coming to the symptoms generally noticed are a previous sibling with failure to thrive, vomiting, respiratory distress, refractory seizures, unexplained jaundice, and coagulopathy. Seizures, floppiness, and intractable hiccups, as well as opsoclonus, myoclonic seizures are seen in non-ketotic hyperglycemia. Screening of parents as well as relatives assumes importance for the prognostication of the condition. And intrauterine diagnosis can be done. Suppose if we have a previous history of suspected IEM related death, intrauterine diagnosis can be done by measurement of the abnormal suspected metabolite in the amniotic fluid, as well as enzyme assay and DNA analysis. And ultrasound for various fetal anomalies can be done, like high drops, ventriculomegaly, and different anomalies can be done antenatally itself. So once the baby is born and the relatively common features like sepsis, asphyxia, intracranial hemorrhage, and metabolic causes like hyperglycemia, hyponatremia, hypernatremia, hypocalcemia, these are all ruled out first, then before evaluating further for IM. Then head-to-toe examination should be done to look for the specific features which we mentioned, like hair and skin abnormalities, dysmorphic features. This is particularly very important in IEMs, and eye examination to look for cataracts, lens dislocation, and organ involvement, organomegaly, and jaundice, polystatic jaundice or not. All these should be done. So first, the baseline investigations in any baby should be a complete blood picture as well as electrolytes, blood glucose, and ABG, particularly to look for the metabolic acidosis and as well as the anion gap. High anion gap is very important to rule in the IEM, as well as liver function tests to look for direct jaundice, coagulation profile. Serum ammonia is very important in the case of hyperammonemia syndromes and lactate. And next, coming to the CSF analysis, CSF amino acids, glucose, lactate, and pyruvate also can be looked for. Urine pH and reducing substances is important. For like non-glucose reducing substances are evaluated in case of galactosemia. So where the baby will be having other features as well. And this is the GALAC workup, which we will come to in the subsequent slides, as well as TMS, plasma amino acid analysis, and urine for GCMS and molecular diagnosis. These are the second line and third line of investigations which we do when we are suspecting IEM. Coming to the genetic tests, like plasma amino acid assay by HPLC, high performance liquid chromatography, as well as urine organic acid assays by GCMS, and acyl carnitine and amino acid profile by TMS. These help in ruling out the amino acid base as well as fatty acid oxidation disorders. And specific enzyme assays like biotinidase enzyme assay, galactose 1-phosphate levels, total galactose levels, and GALT enzyme assays are also possible and available. Urine organic acid by GCMS helps in diagnosing the organic acidemias like propionic acidemia and methyl malic acidemia and fatty acid oxidation defects. And in the TMS, if the elevation of the odd chain acyl carnitines like C3, C5 are more suggestive of organic acidemias, whereas the even chain acyl carnitine elevation is suggestive of the fatty acid oxidation defects. Now let's see the GALAC approach, which is a very useful approach in helping in narrowing down the diagnosis of the inborn errors of metabolism. In this, commonly we will be doing the random blood glucose as well as ABG, lactic acidosis, ammonia, and ketones. So let's see some of the common IEMs and what happens to all these variables in those IEMs. In urea cycle disorders, there will be respiratory alkalosis, which is characteristic of urea cycle disorders, along with high ammonia. Remaining ketones will be normal, lactates will be normal, and glucose is normal. Whereas coming to organic acidemias, there may be hypoglycemia also, low or normal, and there will be acidosis. Metabolic acidosis will be there, and lactate might be high or normal, as well as ammonia and ketones are also high in this case. In maple syrup urine disease, all these parameters are normal except for ketones, which are high. Even ammonia is normal. In fatty acid oxidation defects, ketones will be actually low. Ketones will be low along with glucose. So low ketones, decreased ketones with hypoglycemia is suggestive of fatty acid oxidation defects, in which there will be a mild elevation of lactates, and ammonia is also high. We will also see the flow diagram for the evaluation of hypoglycemia. In galactosemia also, there will be a hypoglycemia with ABG being normal and lactates being normal, but the ammonia will be high and the ketones also will be normal. In fructose 1,6-diphosphate deficiency, there will be a severe acidosis on the ABG with hypoglycemia as well as high lactate, high ammonia, and high ketones. in GST type 1, there will be glucose will be low as well as acidosis, and lactates will be high ammonia and normal ketones. So coming to following this approach, if we do all these like glucose, ABG, lactates, ammonia and ketones and try to fit them in this table, you will be able to come to one group of diagnosis. Like from there you can proceed like based what all further investigations need to be done. So coming to the IEMs and their different presentations, we'll be seeing the first one now. IEM presenting as predominantly metabolic acidosis. Suppose the baby, you had done the blood gas and there is a metabolic acidosis is there. And then you should see whether there is a ketosis or not ketosis. So if the baby is with ketosis is there, ketone bodies are positive and there is a high ammonia, then we should go for lactate. So in this we will be seeing only 3 parameters: metabolic acidosis baby with ketosis, ammonia and lactate. So if then we will be able to come to the diagnosis like we have previously seen. With ketosis and high ammonia with normal lactates will fit into organic asthenias. If lactates are also high, then pyruvate carboxylase deficiency or holocarboxylase synthetase deficiency. If the ammonias are normal, then we will be seeing whether there is a high lactate or not. If there is a high lactate, it will go into one of these categories like GST type 1 and pyruvate carboxylase again, and mitochondrial defects and HCS based on the blood glucose values. If ammonia is normal and there is hypoglycemia as well, then it can be organic asthenia or adrenal insufficiency. And if the blood glucose is normal, then it can be organic asthenia or maple syrup urine disease. So this is about the ketosis. If there is no ketosis with only metabolic acidosis, and if the lactates are also normal, then that is like renal tubular acidosis. It's completely different possibility, or GI losses of bicarbonate or renal losses of bicarbonate. So if there is no ketosis and the lactates are high with hypoglycemia, then we thought of like it can be a fatty acid oxidation defects and HMG CoA deficiency. If there is no hypoglycemia and there is a normoglycemia only, then it is pyruvate dehydrogenase defect. So in this, some of the things we can remember like metabolic acidosis without ketosis and hypoglycemia, you can think of fatty acid oxidation defects if the with high lactate. If the lactates are normal, then either renal or GI losses of bicarbonate. And with ketosis, if there is a high ammonia, you can think of organic acidemias. And if that goes into normal ammonias, you can think of the other causes based on the lactates and sugar levels. So let's see our first case. I have mentioned some examples in this video. So a term 3000 grams birth weight male baby born out of 3rd degree consanguineous parents. So consanguinity is there and antenatal period was uneventful. Baby was well at birth, was started on breastfeeding and there was no significant natal history. Baby presence of feeding and vomiting. So this is the typical presentation of majority of the IEMs. So initially they'll be well at birth and they present with intoxication symptoms on day of life 2-3, first week of life, with poor feeding and vomiting. So on examination, this baby is lethargic. Baby is having seizure activity, hypertonic with opistotonic posturing. So hypertonia with opistotonic posturing and seizure activity. So what could be the possibility? So the labs were done, which showed high anion gap metabolic acidosis with normal lactate and sugars. So this much investigation we can do in any baby who is presenting with seizure activity. We will be definitely doing lactates, blood gas and sugars. So plasma leucine, isoleucine and valine levels were elevated. So branched chain amino acids were elevated. So most likely this will be maple syrup urine disease. Maple syrup urine disease classically presents with hypertonia and opistotonic posturing along with seizure activity with elevation of this leucine, isoleucine and valine. So in this way we can diagnose the case. So coming to the management, withholding the protein intake for the baby and providing the adequate calories either through IV dextrose and decreasing the substrate accumulation by either hemodialysis or peritoneal dialysis for hyperleucinemia. So let's go on. Thiamine trial is given 10 mg per kg per day, which is found to be useful in babies with maple syrup urine disease. This is given for a period of 4 weeks. So let's see the MRI findings in maple syrup urine disease. Here you can see axial diffusion weighted image showing abnormal high intensity in the bilateral optic tracts. This one is the bilateral optic tracts. This is mesencephalon, and this is the hyperintensities in the cerebellar vermis. In this figure, you can see the abnormal high signal intensities in the basal ganglia as well as the thalamus. So this is the characteristic feature of maple syrup urine disease. Coming to the next disorder, that is organic asthenias. So in this there will be 3 groups like asovaleric asthenia, propionic asthenia and methylmalonic asthenia. So organic asthenias will present with hypotonia, truncal hypotonia and limb hypertonia with myoclonic jerks. Lab anomalies will be ammonia levels will be high with ketosis, metabolic acidosis and elevated C3 and C5 on TMS. This we discussed previously also. Neuroimaging MRI will show the cerebral atrophy as well as basal ganglia abnormalities. So management will be similar to MSUD for organic asthenia also. Protein restriction and calorie supplementation. Carnitine is provided at 100 to 300 mg per kg a day as well as vitamin supplementation, biotin, B12 and thiamine. Organic asthenias present more like septic shock kind of presentation. Coming to evaluation of hyperammonemia. So, neonatal hyperammonemia, if it presents in the first 24 hours of life in premature neonates, then it is the transient hyperammonemia of newborn, which will resolve after a few weeks. And if it presents in a full-term baby in the first 24 hours of life, then we should think of organic asthenias and pyruvate carboxylase deficiency. Symptoms presenting after 24 hours of life. If there is acidosis, you think of organic asthenias. If there is no acidosis, then we should go for urea cycle lipids. Then we should measure the plasma amino acids, particularly the citrulline. If the citrulline is absent, then we should measure the urine orotic acid. If urine orotic acid levels are low, then carboxyl phosphate synthase deficiency. The urea cycle will be seen in the next slide. And if it is elevated, then ornithine transcarbamylase deficiency. So then if the citrulline is moderately elevated, then we should look for ASA. Then if it is present, then arginosuccinic aciduria. If citrulline is markedly elevated and there is no ASA, means it is citrullinemia. So this is the urea cycle which we were discussing about. Here we will be seeing for these different products like citrulline and arginosuccinate. So whenever the one of the substrate is absent, then the previous enzyme which is acting on that is the defective enzyme. Suppose if arginosuccinate is in this case we have seen if there is no arginosuccinic acid, then that is citrullinemia. If ASA is present, then that is arginosuccinic aciduria. So let's go to the case 2. This is a term baby who presents on day of life 3 with vomiting and dull activity. On examination, baby is having seizures as well as apnea and hyperventilation. So you can think of many possibilities. Previously, I have mentioned hyperventilation in one of the cases. Blood test revealed respiratory alkalosis, and glucose, ketones, everything was normal, and serum ammonia is very high. It's 800 micromoles per liter. So, what could be the possibility in this case? You can type in the chat box as well. It's a urea cycle defect. So, how do we diagnose these urea cycle defects? By molecular assay, and management is by protein restriction, glucose infusion to maintain the GIR, as well as specific treatment will be sodium benzoate, loading dose of 250 mg per kg, then the same dose given every 6 hourly, followed by hemodialysis or hemofiltration to remove the excessive substrate, as well as treating the seizures, followed by oral sodium benzoate, arginine and citrulline are given further, and we should always try to avoid the triggers like infection, fasting, and the final treatment would be the liver transplant in the cases. So previously we thought of some misconceptions like IMs are never treatable. So many of the IMs have treatment, and those children can live a near normal life also. So we finish the IM with metabolic acidosis. Now let's see the IMs which present mainly as hypoglycemia, that is refractory hypoglycemia, which is needing a GIR of more than 12 mg per kg per minute. In that condition, we should do the blood gas and look for ketones as well. If the ketosis is there, and with ketosis and without ketosis, first let's see hypoglycemia without. So we have finished till here. That is the approach to hypoglycemia. We have covered the different fatty acid oxidation effects. In this, the presenting feature will be lethargy, cardiomyopathy, arrhythmias, hypotonia, hepatomegaly, as well as hypoglycemia with no ketosis, and as we have seen in the previous slide, and high lactate, no ketosis with high lactate and hypoglycemia, along with lethargy, arrhythmias, and cardiomyopathy points towards fatty acid oxidation defects. The management would be first giving IV glucose to maintain the glucose infusion rate, as well as supplementing later with low fat formula and medium chain triglycerides and carnitine supplementation on follow-up. Coming to the third presentation, which is inborn errors of metabolism presenting with liver dysfunction. So I will tell the case details. A term baby who was admitted on day of life 6 for jaundice and dull activity. On examination, the baby had hepatomegaly, coagulopathy, conjugated hyperbilirubinemia, and elevated liver enzymes, that is transaminitis. Baby also had hypoglycemia. So hypoglycemia with jaundice and hepatomegaly, there are only few possibilities like galactosemia, tyrosinemia. So baby was started on IV dextrose, and the blood culture was also positive. So the organism, which is the most likely organism in this condition, like gram-negative sepsis is most common in IMs like galactosemia. E. coli, Klebsiella, these are the most common ones. The culture was positive for E. coli. The ideal test for diagnosing the condition is newborn screening test, in which we can rule out galactosemia. And the enzyme deficiency is galactose 1-phosphate uridyl transferase enzyme. And the treatment is galactose-free diet. So this is the example of IM presenting with liver dysfunction. Coming to the IMs which present with neonatal seizures, these conditions present predominantly with neonatal seizures, although encephalopathy, hypotonia also will be associated with these conditions. They are holocarboxylase synthase deficiency, biotinidase deficiency, pyridoxine dependent epilepsy, pyridoxal phosphate responsive epilepsy, glycine encephalopathy, Zellweger syndrome, and sulfite oxidase and molybdenum cofactor deficiency. If a baby presents predominantly with neonatal seizures, disorders and having IM-like features, we should keep these possibilities in mind. So let's go to the example. A term male baby presents with myoclonic seizures on day 1 of life itself, with profound hypotonia, hiccups, apnea, and progressive lethargy. So the mother felt excessive baby movements in the last trimester. So intrauterine presentation with seizures on day 1 of life itself, with EEG showing burst suppressive pattern, is suggestive of non-ketotic hyperglycemia. It is inherited in an autosomal recessive manner. And opsoclonus myoclonus will be the predominant feature in this presentation. And when we do the CSF, there will be increased CSF glycine to plasma glycine ratio of more than 0.08, the normal being less than 0.04. So sodium benzoate therapy is administered for this condition, and the NKH, which has a neonatal onset, usually has a poor prognosis. Let's go on with our next case. A term 2600 grams baby presents on day 5 of life with seizures. So this is the similar presentation for most of the IMs. The parents had consanguinity, but there were no other complications. Initial workup like blood glucose, electrolytes, lactate, ketones, everything was normal. And the CSF was also normal, and TMS was done for this baby, which was also normal. The baby was started on initially first line of anti-epileptics, and then it was refractory to the treatment. The baby was started also on the midazolam drip. So now the baby had multifocal seizures even on multiple anti-epileptic drugs. So then we should think of what to add next. So the baby is already on multiple anti-epileptics. We can add the pyridoxine next. So the EEG in this baby was suggestive of burst suppression pattern with attenuated background. MRI brain was normal. Investigation revealed only one clue, that is showed high levels of pipecoleic acid and aminoadipic semialdehyde ASA levels. So the diagnosis in this case was shown to be pyridoxine dependent epilepsy, which is one of the causes for refractory seizures, as we have seen before. Suppose if the baby does not respond to pyridoxine also, then the other possibility would be pyridoxal 5-phosphate responsive epilepsy. So in pyridoxine dependent epilepsy, we'll be giving pyridoxine 100 mg IV followed by oral therapy. In pyridoxal phosphate responsive epilepsy, we should give pyridoxal phosphate 50 mg oral can be tried. So we have finished the IM with presenting as neonatal seizures. Then we'll go on to the IMs which present with cardiomyopathy. A baby presents in the second week, 15 days of life, with lethargy and feeding difficulties. On examination, the baby was grossly hypotonic with macroglossia, hepatomegaly, and respiratory distress. So X-ray was done, which showed cardiomegaly. So as we have previously discussed, any baby with cardiomegaly, cardiomyopathy, we should think of storage disorders. So in this, the diagnosis was found to be glycogen storage disease type 2, which was Pompe's disease, deficiency of lysosomal enzyme alpha-glucosidase. So the investigations usually done are serum creatinine kinase and enzyme assays and molecular genetic testing for the same condition. The treatment is enzyme replacement therapy. Even though it is costly, is available, it should be started as soon as the diagnosis is established to avoid the complications. So this is the ECG of the same baby showing short PR interval with giant QRS complexes in all leads. You can see here the QRS complexes are in all the leads, suggestive of biventricular hypertrophy. So coming to the common MRI and MRS findings in various inborn errors of metabolism. So in urea cycle disorders, there will be cortical and subcortical lesions which spare the thalamus, and in MRS there will be elevated glutamine peak. In organic asthenias, there will be cerebral white matter and globus pallidus changes with elevated glycine peak. So in MSUDs, there will be edema involving the brainstem as well as cerebellum. This is as well as vasogenic edema also will be there in this, and elevated branched chain keto acids. In galactosemia, hypoglycemic encephalopathy changes are seen with elevated galactitol peak. In non-ketotic hyperglycemia, there will be corpus callosal agenesis, although this may not be seen in all the cases. There will be corpus callosum hypoplastic hypoplasia will be there with elevated glycine peak. In molybdenum cofactor deficiency, cystic changes of white matter similar to HIE and global brain atrophy kind of features will be seen. In multiple carboxylase deficiency, there will be intraventricular hemorrhage as well as ventriculomegaly with elevated lactate peak on MRS. Zellweger syndrome will show polymicrogyria and ventriculomegaly. So coming to the management of IEMs, so we should first try to decrease the toxic metabolites. So by keeping the baby NPO as soon as we suspect IEM in a baby with encephalopathy and lethargy, and start on maintenance fluids and maintain the glucose infusion rate, we should start treating the infection that is uh, uh, which might be there in the baby when the baby was admitted. So treat the infection also and send the blood culture, send the initial workup, and then introduce feeds after 48 hours with the specialized formula. And we should try to eliminate the toxins. First, we will add carnitine in the case of organic asthenias, sodium benzoate for urea cycle disorders, and sodium phenyl butyrate as well for urea cycle disorders. And elimination of toxins is also done by mainly by hemodialysis and if possible by peritoneal dialysis and renal replacement therapy. And if there is a high jaundice, double volume exchange transfusion should be done for the same. So correction of metabolic acidosis, managing the airway and breathing by connecting the baby to the ventilatory support and treating the seizures and treating the precipitating factors like infection should be done. And we should monitor the baby for intake output balance, glucose levels, as well as bleeding and other biochemical parameters like electrolytes, calcium levels. So substrate reduction is done by keeping the baby NPO initially, later on starting the feed with the specialized formulas. And treatment part like enzyme replacement if available, cofactor replacement if it is available once the diagnosis is made can be done. Some of the cases go for liver transplant or stem cell therapy. Some of the medications which are given for IM or nitisinone is given for tyrosinemia type 1 and metronidazole is given for organic asthenias. So different vitamins are used in the treatment of different IEMs. So you'll see one by one. Carnitine is given in 100 mg per kg per day IV or oral for organic asthenias. Vitamin B12 for methylmalonic asthenia. Thiamine, as we have seen, for maple syrup urine disease. Riboflavin for glutaric aciduria type 1 and 2. Biotin for biotinidase deficiency. Pyridoxine for homocystinuria. So generally we start the metabolic cocktail whenever we suspect a baby to have IEM, which will cover all these vitamins, and based on the report, so we can continue whichever is needed and stop the rest of the medicines. Folinic acid for hereditary orotic aciduria, and if it is a case of congenital lactic acidosis, we should correct the acidosis first and then supplement with the vitamins, thiamine, riboflavin, coenzyme Q, and L-carnitine also should be given. So in the long term, the babies are usually discharged on like specialized formulas in the case of maple syrup urine disease, phenylketonuria, and galactosemia and glycogen storage disorders. Enzyme replacement is available for Pompey's disease. So whenever a baby is born with a previous history of IEM, like previously unexplained sibling death or suspected IEM related death in a previous child, then we should initially start the baby on IV dextrose, and graded EBM can be started cautiously, as we have already discussed. No need to keep the baby away from the mother's milk, considering the number of vital nutrients in the mother's milk, and then we should do the GALAC workup. That is, we have already seen the glucose and ABG, lactate, and the ketones workup, and TMS and GCMS should be done at 48 hours of life. If all these reports turn out to be normal, baby can be continued on direct breastfeeding, but we should continue to monitor this GALAC. And if the reports are abnormal, we should start the specialized formula feeds along with graded EBM. So if the baby goes into metabolic crisis, then we should go to the previous emergency management, which we have already seen. So some of the IEMs are treatable, like transient hyperammonemia of newborn, hyperammonemia, hyperinsulinemia, urea cycle defects generally go for a liver transplant, MSUDs go for diet and liver transplant, multiple carboxylase deficiencies are discharged on biotin. The fatty acid oxidation defects, we should avoid the features like which cause the crisis, like fasting, infection, all these conditions. In HMG coeli also, we should avoid the fasting. In galactosemia, galactose-free diet, and in gluten deficiency, ketogenic diet. So these are some of the examples of IEMs which are treatable. So we are coming to the end of the presentation. So the take-home messages are IEM is possible even if there is no family history. So we should suspect the IEM whenever the baby is having sepsis-like features or refractory seizures or coagulopathy, altered sensorium, and if the cultures come negative. So IEMs can be, most of them can be diagnosed by a algorithmic approach. It's not that difficult to remember if we correlate the clinical signs to the investigations. We can narrow down the diagnosis, and some of the IEMs are treatable, and these children will have a near normal life. And the diagnosis is also easier nowadays with TMS, GCMS, and these newborn screening programs. And the newborn screening should be offered for each and every baby which is getting discharged from the hospital, because since we have seen these, even though these IEMs are individually rare, they are collectively common, and the incidence is coming to around less than 1 in 1,000. So the newborn screening nowadays is mostly very well affordable. So it should be offered to each and every baby, and we should monitor the baby, like in any case of sudden postnatal collapse. So IEM should be always considered as a possibility. Thank you.